Thank you, Rohit. When you look at superior oblique palsy, this is one of the series we published. If you look at it, congenital and traumatic are the most common cause when you look at superior oblique palsies. Traumatic ones, most of them resolve. Congenital ones can confuse you sometimes as an acquired superior oblique palsy because they can present to you very late. So they can come with different head tilts. Most of them, they will have head tilt. If it is a childhood one, if it is acquired sometime, they will come just with the vertical. Head tilt is because of the torsional component of superior oblique palsy, and most of it can be corrected if you do a proper surgery at a proper time. Still, some amount of head tilt still persists even if you do nice surgery, even if they are orthotropic in primary position. So if you look at effect of strabismus surgery, if you can see here, it can successfully treat in most of the patient, but about 1/3 of the patients requires second surgery to correct it. So this is one of the published series where you can see a significant head tilt. She did not get operated. This was when I was in UCLA. She got operated here. Still she got a very good correction, same as in this kid too. So if early surgery is indicated or not, I think it's, as you do early surgery, it's better. Only problem is you may not be able to measure the deviation when the patient comes to you very early, measure the head tilt very properly. So as soon as you get a good measurement, I think it should be done to avoid this residual torticollis in patients after strabismus surgery. This is a textbook classical description of these types of superior oblique palsy. This may not be applicable in every case. Practically, sometimes we may not be able to use this class. This is class 1, where the hypertropia is in down gaze. This is only on the full opposite adducted position. This is adducted as well as lower field. This is lower field, and this is spread of incomitance there. So if you look at treatment, I'm only talking about surgical treatment here. So first and foremost test is traction test. If it is congenital, if there is absent tendon and there is lax tendon. So if there is lax tendon, if the deviation is very small, just any form of inferior oblique weakening is enough. If the lax tendon with significant deviation, for me the cutoff is more than 20 prism diopters, then need to add both. And if there is absent tendon, you might have to explore the superior oblique, because in cases of very lax traction test, it's always good idea to open up and then see. You might have to do a little bit significant surgery there. In acquired, this is the algorithm. If hypertropia is less than 15 prism diopters and do the inferior oblique weakening. If there is superior oblique restriction is not there, if it is there, do a superior rectus recession. Sometimes because of the constant hypertropia, they can have contracture of the superior rectus. That's why forced duction test as well as forced traction test is very important. If there is nothing, you can go on to the other eye, that is contralateral inferior rectus. This is very safe to do, because sometimes if you do a superior rectus recession on the same side, you weaken the inferior oblique also. So elevation becomes really not balanced. So that's what we would do in this kind of. So just to demonstrate, how do you find out this lax tendon? So this is the traction test as well as forced duction test. You hold at these 2 points and fingers are coming here. You can really rotate. So you need to do a lot of patients with normal this traction test, and then you will know. You can see here, you can't see the limbus at all. So that means it's a proprioceptive feeling. It's not like movement as such, like FDT. You can feel it, how tight it is or how lax it is. As in this case, this is a case of Brown syndrome. You can see this is the forced duction test. And if we are doing force, this is again horizontal muscles, forced duction test. They are all right here. And if you do a forced traction test, you can see the difference between the previous case and this case. This is important because once you do a superior oblique tuck, how much to tighten? So these are the landmarks. I think everyone should know what is too tight. Second one is, this is the correct amount of Brown syndrome you should do, and if it goes beyond this, that's very loose muscle. So this should not happen. Maybe you should bring this looseness till here so that you get adequate superior oblique tuck. I would like to present a case here. 4 years old male. Usually parents, for insurance purpose, even if they see from a long time, they'll just say 4 months, which you can confirm. This is the left face turn with 5 degrees, left head with 10 degrees. You can see a very huge, this is 30 prisms, I think, yeah, 30 prism diopters of right hypertropia here, and significant inferior oblique overaction, and you can see it's increasing up to 35 in the up gaze and less in down gaze, and you can see the superior oblique action here as well as here. When you compare, there is significant underaction, and you can do a Belchowski head test with the glasses. You can see what's the difference between the right head tilt as well as in the left head tilt. So this is called fallen eye. So most of the time they will have their pictures, so you can go back. You can see already there is a hypertropia here. So you know that it's mostly a congenital superior oblique palsy. For insurance purpose, most of the parents hide that thing. So he had a tilt earlier, everything is there. So these are the deciding factors for surgical consideration. Magnitude of the deviation in primary position. For me, the cutoff is 15 to 20 prism diopters. I would do one muscle. Beyond 20 to 25, it's a kind of borderline depending upon how much lax your muscle is. Beyond 25, it's 100% you'll have to do 2 muscles. And then versions, presence or absence of inferior oblique overaction matters a lot. And obviously in acquired cases, the torsion as well as the superior rectus contracture and superior oblique tendon laxity. So this is pictures of superior oblique tuck. You can see how lax it was. See, this is the force traction test pictures, and we are opening. It's a very thin muscle. When you open it, see the amount of laxity on the superior oblique. It's very lax. This is not the normal muscle. When you hook, you don't. Most of the times we don't hook a normal muscle, but sometimes when you do, at least for the beginners, when you do a superior rectus surgery, better to hook once and see. Again, these are all not by appearance. You need to feel the muscle. Then only we can take this decision. So it's a quite lax muscle. So we are trying to do a 11 millimeter. It's on both sides. I'm doing approximately 20 millimeter tuck here. So putting a non-absorbable suture. So, and then this is optional. I try to put one more suture so that that folded portion comes back. I don't want any kind of hump there. I just put it back in that kind of position. And this is simple inferior oblique weakening procedure I am doing, steps of the same. So after 6 weeks, this is the appearance of the patient here. You can see a significant improvement in the superior oblique function as well. His head tilt has gone down. This is the pre and post operative picture. There is improvement on both the things. So another case, always it's not only vertical, they can also have significant horizontal deviation with superior oblique palsy. So you can see, if he fixes with this eye, you can see a significant amount of hypertropia. Here there is hypertropia. So this is, he has a large XT with the V pattern. You can see very significant inferior oblique overaction. I would say almost 4+. You can see the underaction here. And then these are the measurement. He has hypertropia of 30 with 70 prisms of exotropia. You know that you'll have to manage many muscles here. So again, the patient had surgery both on superior oblique tuck as well as inferior oblique weakening, because it's better to not to do any superior rectus surgery in this kind of situations, because you already have to tackle 3 horizontal muscles here. So this is the head tilt picture. Right head tilt he has 40, and on left head tilt it's still not 0. He has 15 prism diopters of hypertropia, and this is his fundus pictures. This is very important, especially in acquired cases, to look at the torsional. So he had tuck along with 3 horizontal rectus muscle for his exotropia. You can see there is a significant improvement, not perfect, but still he is not having any problem with the diplopia or anything. You can see even on head tilt, it's not completely corrected. This is one of the problems. You can't correct in every gaze. So this is the pre-operative and post-operative. This is the last picture patient I want to show. He comes with a minimal right head tilt, and here he has less than 15 prism diopters. What we did is we just weakened this overacting inferior oblique. That's it. That took care of his head tilt as well as everything. This is one of the patient who had exotropia with right hypertropia. These are the measurement. You can see 35 and 20 here. The operating surgeon has done inferior oblique only here. These are the post-operative picture, and still he has hypertropia. You can see inferior oblique is done. Still there is significant inferior oblique overaction. So we went back, there was residual fibers there, and that corrected the inferior oblique overaction. So this is the first visit. This is after first surgery, and this is after the second surgery. So only situation here, some people can go ahead with the superior oblique tuck. Probably it's not required, because this suggests that there is residual inferior oblique overaction. You just tackle this, that will take care of everything. So I think that's about it. Thank you very much.